Hello. Yeah.
Hey, hello, hello.
Hey, Matt. How are you?
Pretty good. How you doing?
I'm very good. I'm very good. Thanks for having me on.
Yeah, thanks for coming on. Just so you know, we're live, so don't say anything personal identifying or anything like that.
Yeah, cool.
Do you want to give
Um,
yourself some kind of introduction so people know who you are?
yeah, sure. So I'm a doctor from Australia. I've been working as a doctor for the past 5 years or so. I think I'm about the same age as you, turning 30. In terms of my relationship with like Twitch and gaming, etc. Um, so back when I was in my university years, I used to play some games like Dota and League and stuff. I don't play as much anymore,
Mm-hmm.
and I've never really watched Twitch or streams per se, but I do watch a lot of YouTube clips of both yourself and some other streamers, so I kind of know what's going on in that sphere. Obviously, lately there's all the talk of the sexual harassment claims, and the other thing was the passing of Reckful,
Mm-hmm.
which was obviously very sad. Um, and so I watched, I had watched his Dr. K streams, and I watched some of Dr. K's other streams, which I think are really good. I think he's a really great psychiatrist, from what I can tell.
Mm-hmm.
And I saw some of the reactions and discussions after his death, like on the Trainwrecks podcast with Dr. K, and I also saw one of your videos talking about the experiences of people with depression and the graph and everything. And I thought that was a good place to start
Okay.
because I had some thoughts about that. So I thought like it was a good way to sort of try and communicate the feelings of someone with who is in a sort of a major depressive episode,
Mm-hmm.
in the sense that they don't have that drive to actually, as you said, sort of want to be happy or become happy
Mm-hmm.
or do things to improve their own physical and mental state. It's a pretty good analogy, that graph. The only thing I wanted to point out with that, and I think Dr. K actually went through this a little bit. He did mention this, but that sort of chronic low baseline that you sort of drew on the graph,
Mm-hmm.
where someone has just a permanent level of happiness that is lower than what it should be,
Yeah.
and then they fluctuate from there. That is more that's called, we call it dysthymia, and it's not exactly the same as major depressive disorder, although there are lots of overlaps, and this is all more of a spectrum in psychiatry rather than clear categories.
Sure.
Major depression or major depressive disorder uh, is usually transient, or at least fluctuating, in the sense that you have um,
Good periods and bad periods.
good periods and bad periods. The periods that are bad have to last at least 2 weeks,
Mm-hmm.
and those periods have to include at least several categories of symptoms, things like anhedonia, which is not being able to experience joy, usually loss of appetite,
Mm-hmm.
losing weight, can't sleep, your thought and movement becomes slowed, recurrent feelings of worthlessness, suicidal thoughts, things like that.
Mm-hmm.
And the dysthymia, which is more of a sort of chronic low baseline, can be simultaneous with that. But as Dr. K was saying, depression and dysthymia and all these things, as you said, are more of a spectrum.
Sure.
However, with Reckful, as far as I'm aware, he had bipolar disorder, and bipolar disorder is a bit different in the sense that your baseline fluctuates a lot. So for him, he would have states of what you would call basically major depression,
Mm-hmm.
fluctuating with states of either hypomania or mania, which are these, complete, manic states where you have grandiose ideas, often some delusions about things. Probably, I think that Kanye West is having a manic episode at the moment. I could be wrong about that, but it seems like that.
Sure.
Um, and so I think one thing that Dr. K said, I don't know if you heard him talk about this, it might have been before you were on the podcast, was that we have sort of solved the body in a lot of ways. In the sense that, I know it sounds a bit weird, but what he was trying to say is that obviously we can't treat and cure everything, but in general, we kind of get the mechanisms of most disease processes in the body down to a cellular level. We understand risk factors. We can develop medical treatments, procedures, surgeries that can be very, very complicated. We can't do anything near that for mental health. There is no surgery to help with mental health.
Mm-hmm.
I mean, there used to be a lot of lobotomies and things like that, but obviously that wasn't a great path. And even with the psychiatric medications that we use, we generally know like the basics of how they work. Like we know, like SSRIs, they block the reuptake of serotonin and things like that. But we don't really, it's really hard to know how they actually affect mental states, how they affect depression, how they affect dysthymia, how they affect bipolar.
Yeah.
We use things like lithium is one of a very, very old drug that we use for bipolar disorder.
Yeah.
It's called a mood stabilizer.
Mm-hmm.
And we really don't know like what it does. Like,
Yeah, a lot of it
we
seems to
can
be kind of
understand
scattershotty. Yeah.
Yeah, exactly. And the other problem with psychiatry, which is why it's so difficult and why most doctors avoid it like the plague, is in medicine, you kind of have, when you approach a patient in medicine, you kind of have three things at your disposal. You have the history, the exam, and the investigation. So the history is what the patient tells you. They've come to you usually with some sort of presenting symptom, some presenting complaint.
Mm-hmm.
And then you say, okay, you ask probing questions to try and find out more details, and then you go onto their medical history, what medications they're on, everything, and then you can go to examination, which
Mm-hmm.
is a physical exam. So like, if someone comes in with abdominal pain, you're going to listen to their heart, listen to their lungs, feel their abdomen. If you need to do a PR exam, all that sort of stuff, the physical exam, and then the last part, which is the probably the most sort of affected by technology and one that's rapidly improving over the recent years, is investigations. So that just includes blood tests, urine tests, imaging, X-rays, CTs, MRIs, all that sort of stuff.
Mm-hmm.
Right. So normally with most patients, you have all of these things at your disposal. With psychiatry, you've just got history.
Mm-hmm.
There's almost, I mean, with some exceptions, there's almost nothing on physical exam that you can find. The examination in psychiatry is called the mental state exam, which is basically what you're gauging from talking to them, what their behavior is like, what their mood and affect is like.
Yeah. To draw an analogy, you can't do like an like an EKG or whatever, like an MRI of the brain to just figure out like what's going on in your head. Do you have depression or whatever? All of it has to be done like verbally. The reporting is really important.
Yeah, exactly. And in fact, when patients present with psychiatric symptoms that are atypical for their sort of age group, like for instance, if you have a 65-year-old lady who presents with a first episode psychosis,
Mm-hmm.
so like she's hearing voices and she's basically just gone nuts.
Mm-hmm.
When that happens,
Wait, hold on, wait. Let's be a little bit more concise. So when we say someone has psychosis, like their senses aren't accurately reporting what's going on, right? They're either seeing something or hearing something that doesn't exist, right?
Okay.
Okay, yeah, sorry.
Let me rephrase.
Okay, yeah.
Psychosis.
Mm-hmm.
So there can be a few features of psychosis, and usually it'll be things like delusions, hallucinations, paranoia.
Mm-hmm.
You can have negative symptoms as well. So the classic cause of psychosis is schizophrenia. There's a lot of other causes, but the common one and the one that people know about most is schizophrenia.
Mm-hmm.
Schizophrenia is sort of characterized by we call positive and negative symptoms. So negative symptoms are the things that you don't have that you should have. So apathy, it can disturb your mental function, sleep, all these types of things. Positive symptoms are things that are extraneous to what you normally do have. So things like auditory hallucinations is a classic one with schizophrenia. Hearing voices
Mm-hmm.
is very common. Paranoid delusions, things like that. So a psychotic episode is essentially when people are displaying those types of symptoms.
Sure.
And maybe acting on those symptoms. So for instance, if someone hears voices telling them that they need to kill someone and then they try to actually harm that person or whatever it is. So when these things happen in a patient that you do not expect it to normally happen. So schizophrenia is a condition that is normally, we believe it sort of starts in your youth. We don't know exactly what happens. like why it happens. We think a lot of it is genetic, but it seems to sort of ramp up by your sort of late teens, early 20s, and if you get a patient who's say 65 years old, lived their whole life, no problems, very sort of stable, and then they have a first episode of psychosis, what we have to do is actually do his sort of a full examination, investigation, MRIs, blood tests, because it's so atypical that we think it probably isn't a sort of quote unquote psychiatric cause. So we
But there
actually
could be
want to
things
rule
like,
out.
because like I think like thyroid problems can cause like memory issues or something. Like it might not necessarily be like related to the brain or something like that, right?
Yeah, absolutely. So like hormonal imbalances with hypo or hypothyroidism and other things, and also just brain tumors or brain infections, encephalitis, things like that.
Sure.
So we use tests like that to basically show that something isn't a psych cause. Is my point. When we sort of rule out the what we call organic causes of psychosis, then we sort of say, okay, now this is a psych problem, and then you're stuck with just talking to the patient.
Sure.
And that's really difficult, especially when a lot of patients in psychiatry often don't want your help. It makes it even more difficult. This is one of the reasons that I don't know exactly if this is the same in America, but in Australia, psychiatry is probably one of the least coveted sort of specialties. Like very few people actually want to do psychiatry here, because it's when you're working in a hospital and you have to do a psychiatry consult, for instance, it's usually just the patient that is causing you the most trouble, is really hard to deal with, all that sort of stuff. So unfortunately what happens here is that a lot of doctors who can't really get into the field they want to will then end up going and
filter
doing
down into psychiatry.
Yeah, or GP, general practice.
So in Australia, you're saying the psychiatrists and the general practitioners are the gym teachers of the hospital.
Okay. Let's not escalate to such a hot take.
Okay.
There are a lot of really good psychiatrists. GPs is different because GPs. So in America, I don't know exactly how it works, but I heard once that the statistic was in Australia we have, for every one specialist, we have 5 general practitioners. In America, it's for every one GP, there are 5 specialists. That may not be entirely accurate. I heard this a long time ago from a tutor of mine, but it's the whole point is the referral system in the US. You don't, as far as I know, you don't necessarily need to see a GP before you see a specialist. Is that right?
Oh man, don't misquote me, but I think you generally need to see a GP to get a referral to a specialist. Depending on what specifically your issue is, you might be able to schedule directly with a specialist, but usually most specialists will want to see a referral from a GP. Otherwise, you'd be wasting a bunch of people's times, I think.
Yeah, okay, well, that's good. I didn't know that. But my point was that there's quite a lot of GPs. GPs is by far the most common field of medicine here, which is good, and as it should be.
Yeah.
So there's a lot of good GPs. There are occasionally those who don't get into their surgical specialties. And mind you, when I say people can't get into their specialties and then decide to do GP or psych, it doesn't mean they're bad doctors. I mean, some of these fields of medicine are very, very competitive. Like, Australia has a population of about 25 million. And if you want to do, let's say plastic surgery or ear, nose, throat surgery, every year in Australia, they probably take maybe like 10 or sometimes even less. It's very competitive.
Sure.
And so you can imagine there's a lot of people who get trapped in this path of doing work, research in this one field, and they're applying year after year and they just can't get on. And then they're just like, screw this, I'm going to go do general practice. And often they're quite good doctors and often they've done a lot. They're just not at that complete top 5 level or something.
Okay.
Yeah. But for some reason with psychiatry, it's that they can't turn people away because we just need more psychiatrists. And some psychiatrists are not the best. I'll say it like that. Some are really good, and the ones who are sort of in it because they love it are fantastic.
Sure.
And I think people like Dr. K, he seems. I mean, look, I personally, I should have probably put this at the start. I'm not training in psychiatry. I'm more on the surgical side of things, but He seems like an excellent psychiatrist from what I've seen.
Mm-hmm.
I haven't watched everything he's done. I've watched a few of his interviews with streamers, and I think he has a really good approach.
Mm-hmm.
I think the problem most people have is if they have a psychiatrist who they don't mesh with, or they don't feel like they understand their issues, and that's very plausible and very common, then they feel like psychiatry can't help them.
Yeah.
I want to just emphasize to your stream and whoever's listening, I guess, that if you see a psychologist or psychiatrist and you just feel like it's not helping at all, it's worth trying at least one or two others.
Mm-hmm.
It's annoying to have to go back to your GP, get another referral, or whatever the process is. It is a bit annoying and irritating. You have to go to a new person and pay more money, whatever that is. But it's often better to try a few others. And if you can talk to people who you know have seen one or can recommend one, that's probably best. So it's not that psychiatry or psychotherapy can't help you. It really depends on the person.
Mm-hmm.
So like psychiatry is one of those fields where being a good doctor in that field makes such a difference. Obviously, like every doctor needs to be a good doctor in their field, but with psychiatry, because it's your therapy, for the most part, I mean, there are medications, of course, but a lot of your therapy is your rapport with the patient, talking to the patient.
Yeah, there's probably, I imagine there's like a level of personalization there that's going to vary from every single person to every single doctor. Whereas like a double bypass surgery, there's probably a pretty standard way to do it that works on like 99% of hearts. Not to downplay the difficulties of surgery or whatever, but that everything is incredibly personalized when it comes to, I guess, like psychiatric or psychological relationships.
100%. And you're right. Like, as difficult as surgeries are, you have your objective measurements of what's happening. You can prepare for the comorbidities of the patient. This patient's a diabetic. This patient has, really bad lung function. You get the anaesthetist to review them. You can do all this almost without talking to them. Like, obviously you're going to talk to the patient, but you know what I mean? Like, you can write down a list of the issues that they have. You can measure how bad their lung function is. You can, get the anaesthetist to do blood tests and check these things before surgery.
Mm-hmm.
You can tailor these things. You can't do that. The equivalent for a patient is actually talking to them. And if they don't tell you the right things or want to tell you the right things, you're kind of stuck. Though, and as by the same token, the DSM, which is the book of psychiatric diagnoses, is constantly sort of evolving based on the patterns of disease that we see.
Mm-hmm.
Back in the day, I'm sure everyone knows that, the DSM had some pretty bad diagnosis in there,
Mm-hmm.
and it's getting a lot better. But it is really, as Dr. K said, it's one of the least understood parts of medicine.
Sure.
It is really hard. To like the brain is just so complicated, and you can't really, as you said, you can't do a blood test on it. You can't really do, you can't measure someone's serotonin levels. You can do scans, but they we don't really have the technology to allow us to do, good enough functional MRI imaging that tells us exactly why a person is thinking this or that. It's very, very complicated.
Yeah.
To give you like an example of how complicated the brain is, have you ever seen kids with a squint, like an inturned or outturned eye?
An interned or outturned eye? I don't think so.
So like cross-eyed.
Okay, sure. Yes.
Or kids with patches on their eye, or really, really big glasses that makes their eyes look massive.
Yeah.
Have you seen this? Yeah. The reason what that is, so in your eye muscles, sometimes you have an eye muscle that is overactive or underactive or pulled too taut.
Mm-hmm.
And what happens is normally your brain kind of adjusts your eyes to align to an image.
Mm-hmm.
But if the tension on one of those eyes is too much and pulling it, let's say outwards, so let's say your left eye is pulled all the way out to the left, your brain is not able to actually fine tune it to pull it back to the center. And so what it does is it says, okay, well, stuff that. I'm just going to ignore the image that left eye is seeing. Because normally what you do is you look at things with both eyes, your brain receives an image from the left eye, an image from the right eye, fuses them together, and gives you a single image.
Mm-hmm.
But if you have an image from your left eye, an image from your right eye that are very different, your brain has to pick one and ignore the other one.
Mm-hmm.
And so what happens in your childhood years, when your brain is still developing in what we call like plastic, is that it sees the two images, it says this left eye image is worthless, so it will then suppress the signals being sent from the left eye.
Mm-hmm.
And normally you have signals from the left eye and the right eye that reach the back of your brain, which is the visual cortex.
Yeah.
And so the brain then actually blocks off the signals from reaching one side and then actually transfers the signals from the right eye to where the left eye would normally receive them. And so that part of the brain that would normally receive signals from the left eye now gets signals from the right eye. So you now have two, like the left and right part of your brain, all receiving signals from one eye. And so if you don't treat that eye, by the time they're about 8 or 9 years old, they completely become blind, or at least very blurry in that left eye.
Mm-hmm.
Even if you fix the eye afterwards, if you fix the muscles, you do surgery, and your eye itself is completely normal and healthy, they become, we call that a lazy eye,
Sure.
amblyopia.
Real quick, oh, I'm sorry. Could you pull the microphone down just a little bit? Sometimes when you breathe into it, we hear it, but
Oh, sorry.
no problem. Okay, keep going.
I saw you did an interview with Dr. K. How did you feel that went?
I felt like it went okay.
Do you think he mentioned anything to you that was of value? Just out of curiosity.
Yeah, I mean, I appreciated his yeah, maybe.
I mean, look, I think it was more of a thing where your stream just wanted you
to cry in front of a
Go
doctor or
on.
whatever. Yeah, I feel like I'm I don't like talking about my own mental status too much because it feels really jerk offy or whatever. I feel like a lot of people that talk to Dr. K have a lot of confusion about their own mental state. Like they're not even necessarily sure how they feel about some things, or they're confused about feelings that they have about a lot of things. And that usually, like a really great thing that he does is he kind of like helps walk people through like, why do you feel a particular way about a thing, or what's making you feel a particular way, or what's the source of your frustration. I feel like I have a pretty good understanding of most of that in my life. Like I don't know if there's a lot of insight to be gleaned from somebody telling me like, oh, well, you're actually upset about this thing. Like I don't think I just don't think I'm in an area where that is possible right now, because I feel like I have a pretty good understanding of what makes me happy, what makes me sad. I don't have like these mysterious sources of stress or anxiety or whatever. The idea about being maybe like a little bit more emotionally engaged with the world is something I've considered. I mean, I've considered it. Dr. K told me to consider it. Like I'm still considering it, but yeah.
No, that's fair enough. And you're right. Like
Mm-hmm.
that is the goal of a psychiatrist, is to try and to almost be like a mirror that kind of points you in the right direction of what you're meant to look at.
Yeah.
Like he obviously does a very good job at asking those probing questions,
Mm-hmm.
and seeing like, why do you think you do this, and try and understand yourself without being judgmental or, you're not meant to, or, this is a weird thing to say, but as a psychiatrist, you're not really meant to have like a strong personality when you talk to someone. You're really just trying to make someone almost talk back to themselves and guide their own conversation.
Yeah, you're like reflective and Socratic or whatever, kind of, right? You're just helping people, walking people through the doors of their own mind, and then hopefully helping them understand something that's wrong with them, or not something that's wrong with them, but something that they want to fix or whatever, something that might be unhealthy or whatever.
Yeah, and I think you probably do have a good level of introspection and reflectiveness, that you probably have thought about a lot of the stuff that he was, trying to ask you.
Mm-hmm.
And I'm assuming he didn't know much about you before he interviewed you.
Yeah.
Cool. So now you mentioned at one point, and I can't remember exactly what you said, but I remember there was a video where you discussed when you saw your doctor, like your general doctor,
Mm-hmm.
and you had a very unusual or weird experience with them.
Oh, no, I just kind of had a pretty negative experience where I felt like, for me, I don't really care much about people's judgments, because it's whatever it's kind of person I was. But if I was a different kind of person, I think it would turn me off a lot from being honest with doctors.
Yeah.
It was just basically, it was like a really quick thing of like recanting, like it was like drug and sexual experiences, and I got a lecture on like every single thing that I brought up, and it felt like pretty dumb, but maybe they felt obligated to say it. I don't know. I felt like it could have been delivered in a way that was a little bit less condescending, but
Yeah.
And then it makes me wonder about a lot of other things too. Dare for a long time hurt my engagement with a lot of like health related things, because like after you find out, do you know what Dare is? Sorry.
No, what's Dare?
It's a horrendously, incredibly, infuriatingly stupid anti-drug program in the United States. Like if you smoke weed, your brain is gonna fall out of your head or something. Just like really dumb. And like listening to the person that I came to see as a doctor tell me that like doing 1 tab of LSD, you know, could cause like lifelong heart problems or whatever crazy stuff she was saying. I was like, okay, whatever. It just felt like really, yeah, it was like really, really, really dumb. Like I have I've done like 4 or 5 drugs over the past year, but most of them are pretty tame. It's like mushrooms, LSD, weed, like MDMA, and like for every single one of these that I brought up, I got like these are like the 7 or 8 different things that might happen to you or whatever. And it's like, okay, I don't know, it just felt really silly.
Yeah, if it's any consolation, some of the people who I went to medical school with were you know had experimented with some of those same drugs, and I think when you have knowledge of different drugs, what they do, what their potential for harm is, you know the ones to avoid. You're not going to go, you know, doing heroin. You're not going to be, you know, smoking methamphetamine ice. Like, you know, you kind of know the really dangerous ones, especially when you do, you know, a drug and alcohol term, and you go into that. You know, the rehabilitation area or whatever it is, and the big ones are alcohol, heroin, ice. People don't come in because they're addicted to mushrooms, or, you know, it's pretty rare that people come in addicted to marijuana. It does happen.
Yeah, of course.
But it's pretty unusual.
Yeah. I mean, I can understand the like. I mean, it's good to be aware of like risk factors associated with things. I think that's always good. It just felt like really.
Look,
like she had me get like she ordered like a workup of like my kidneys or whatever and my liver, because I told her that like sometimes I get wasted twice a year. So I got like it felt like a little bit weird. I was like, okay,
I see. So yeah, when you say a workup of your kidneys and liver, I mean, look, to a doctor, like I assume what she did was like two blood tests, or
yes, yeah, it was two, it was a blood test, to make sure that my kidneys and liver were functioning, whatever that means.
Yeah, look, so the 2 like common blood tests that we do for like pretty much everyone. So let's say you're working in emergency, someone comes in with anything that you think, we should just have a quick look at what their bloods are. You usually do a full blood count, which shows you your hemoglobin, shows you your white cells, if they're high or low. If they're higher, that might be an infection. Shows you your platelet level, shows you a few other things. And then you do what's called EUC, which is like your electrolytes and your creatinine and urea. And that basically shows you things like sodium, potassium, bicarbonate. It shows you your kidney function. So even in like young patients, you know, like let's say you have a young girl who you think has appendicitis, you know, you're going to do that blood test almost as part of the general workup.
Sure.
And you know, if you had like a general health checkup, and you didn't even tell me that you did any drugs, and I just wanted to do a general blood screen, that would be in there. I'd be doing the EUCs. I'd also do liver function tests, just because it's, again, these are not too expensive, and
and I was there for a physical anyway, so like I'm actually totally empathetic to that. I don't think any of the tests today were wrong. I just thought that the delivery was like a little bit strange. Like I could see other people. Like one of the big complaints I hear about people that have trouble with therapists is that they oftentimes feel either misunderstood or very judged. That they feel like the therapist might be moralizing a lot of things that makes them feel uncomfortable, and then they don't want to go back or whatever. And if I was the kind of person that worried about stuff like that, I would have definitely felt it from this doctor for sure.
Yeah, I can see that, and you're right. And I mean, it's important for general practice, probably even more important for psych or counselling or therapy. But you can't. I mean, you just can't. You can't be judgmental, because you're going to have patients who are doing the wrong thing.
Yeah, of course.
You know, and telling a patient who smokes and has been smoking for 50 years, you know, that's bad. You know, you're going to die. Like it's your duty to try and get them to stop smoking, but by preaching to someone, it's not going to change their mind. You know, you have to try and have a bit of a better strategy. You got to try and frame it around that patient's experiences a bit. It's hard, you know, and especially if a patient doesn't want to change something. When a patient comes into hospital and they have some sort of, you know, psych issue that's not affecting them, right? Or let's say a patient comes in who drinks a lot of alcohol, you know, like a lot of alcohol, like 3 liters of wine a day, 4 liters of wine a day, but they've come in because they have something unrelated, like a cellulitis of their leg. If you're treating them for the cellulitis, you give them the antibiotics. They tell you, oh, yeah, I drink about 3 liters of wine a day. And you say, well, okay, do you want someone to talk to about that? We can bring our drug and alcohol doctors over and they can have a chat with you. And they say, no, that's the end of it. You can't,
Yeah.
like, you don't even do the consult. You just leave it because there's no point. The drug and alcohol doctors come along. They're going to tell them all the bad effects of drinking alcohol, the options of treatment, and the patient's going to go, actually, I quite like my wine, so piss off, basically.
Sure.
So if a patient doesn't want help, moralizing or preaching to them isn't going to change much. So I understand that. Now, the other thing I wanted to talk about is COVID. Obviously, a big topic right now.
Something that you said something earlier about how I think or Dr. K said something about how like we figured out the body, but we haven't figured out the mind or something.
Yeah.
I feel like one of the things that sucks with treating mental illness is that I kind of wonder if I don't know if our understanding of like the mind and the body is so far apart as it seems like in treatment. It feels like the bigger difference is that we can live like with depression of the body, but it seems like if we go to a psychologist, we can't really live with like depression of the mind. So for instance, if we go to a psychologist because we have depression, we don't expect them to treat us up to where we're just not killing ourselves, but we expect them to like kind of like make us happier or get us to a point where we can like become happier. But it feels like when we go to doctors for physical issues, literally the point of going inside of a hospital is to just make sure that you don't die. So for example, like when I say like depression of the body, I might say something like being morbidly obese. No doctor you go into can ever cure you of like morbid obesity, short of like gastric bypass or something like that. But like we go in, we get like a ton of blood thinners so that you're just not dying at that point in time. Maybe you get, shot up with a fuck ton of insulin so that you're not, you don't have diabetic neuropathy or whatever. And then you basically walk out and that's okay. Like our bodies can live in those states for a long time and we're okay like walking out with that. But it seems for problems of the mind, it seems like we have a much higher threshold for what we consider successful treatment. And yeah, that seems to be like a really frustrating aspect of like that mind-body idea.
Yeah, I get what you're saying. I think
that like if you were to send somebody, like sending a patient out with like a fuck ton of I keep saying a fuck ton, it's kind of mean, but like if I send like a type 2 diabetic patient out of my office and I've got him a ton of insulin and I'm giving him other medication to treat like his heart problems or whatever, right? I'm not actually getting him more exercise or getting him a better diet or getting him a better sleep schedule. I'm just like making him not die. But if I got like a mentally ill person that was suicidal and I just shot him up with a ton of tranquilizers and sent him out, psychiatrically that would be a failure. But like medically for the body, it seems to be somewhat of a success, right? As long as they're not dying when they're in the office and you send them out, like it's okay. But it seems like you don't get that much leeway from a psychiatric point of view.
Yeah. Okay. So with the physical stuff, so let's say diabetes, heart disease, this sort of what we call non-communicable diseases, things that are diseases that you develop often because of either genetics or your environment or your lifestyle.
Yeah.
As you said, when you go into hospital, let's say a diabetic goes in because they have an acute crisis, something like, I won't go into details, but let's say you have an acute episode, your blood sugar is really, really, really high, to the point of becoming comatose. What you do is you go into the emergency department and you get brought into the emergency department. You get whatever emergency treatment needs to be done. You get all the blood tests, you get the history of the exam. Often you'll get admitted to hospital under a team that is responsible for your care. In this case, you'd have like the endocrine team who treats you, and then you get, they will try to change your medications, make you sure you're, as you said, stabilized to your sort of baseline level that you would have been before this acute episode. They will sometimes try to improve your baseline. So for instance, often we have patients who are non-compliant or homeless who have diabetes, and they either don't take their medications or can't get their medications, and they come in because of that. And then, we will try to either link them up with services, with, specific clinics designed for those types of patients, give them scripts to get medications for cheaper, try to improve their baseline a little bit. But as you said, it's up to the patient to do that. We can't, give the patient 10
life guidance.
Yeah, we can't give them everything. So we'll give them a discharge summary. We write the instructions of what you need to do to be better than you were before, the right medications. We do everything in our power to do that. And like sometimes it works, a lot of the times it doesn't work. But as you said, you can't change a patient's lifestyle, especially in a hospital setting. The hospital is really a place for acute problems, and once you've dealt with the acute problems, no one wants to keep a patient in hospital to try and give them therapy or ongoing discussions about long-term goals. Like once their acute problems sorted, generally you try and discharge them because you're taking up a hospital bed that is needed by someone else at that point.
Yeah.
So yeah, the hospital setting, I agree. You're kind of treating the acute problem, getting them at least back to baseline. If you can do more, that's a bonus, but usually it's not. And then you discharge them home. I would say that there's a slight difference between that and the I think you guys call it primary care or general practice.
Sure.
But in that sense, you're not often seeing, I mean, you often do see patients for acute problems, but a lot of the times you will see patients for more chronic issues. Like patients with heart disease or diabetes, they may not have an acute episode, but they're going to see their GP every 6 months because they need to check their sugar levels, they need to get their blood tests, they need to see if they need to be adjusting their medications at all. And so there's nothing acutely going on with them. It's more of like, as you would say, a checkup. That is when the GP or whichever doctor is trying to improve their baseline. And it's not always successful. It's usually not successful.
Sure, but like in terms of that, like whatever you're improving the baseline to is going to be far less than if the person would just make some lifestyle changes, I guess, is like the frustrating
That's what
part.
I mean.
Yeah.
So like in terms of improving the baseline, you do what you can with medications. If someone has heart disease and diabetes, you give them the blood pressure tablets, you give them cholesterol tablets, you give them whatever diabetic medications they need. But at the end of the day, like the first line treatment for all of these conditions before medications is
diet and
lifestyle
exercise. Yeah, it's really frustrating because people complain so much about like the pharmaceuticals just want to pump you full. Like your doctor just wants to prescribe drugs. I was like, well, the only thing your doctor can do is prescribe drugs. He can't put you on a fucking treadmill and give you, like a salad to eat. Like there's nothing else they could do. It's really frustrating. Yeah.
I agree with that. It is really frustrating because you'll have these really overweight
patients that come in for the same blood pressure medication or diabetes medication, and everything is getting worse and worse. And
you can't not treat them. The problem is, you can do diet and exercise to lower your cholesterol, or you give a statin tablet once a day, and they probably have about the same effect. And so obviously they work synergistically as well. The ideal would be to do both, but when a patient's in their early stages of at being at risk of heart disease, for instance. So you do a blood test and you just notice incidentally they have a little bit of high cholesterol. You don't jump to giving them a medication. You say, hey, go do some exercise, 30 minutes a day for 5 days a week. Try and avoid these foods. Try and eat more of these foods. Come back in 6 months. We'll retest your cholesterol, see how you're going. And then they'll go home, come back. In a very small number of cases, their cholesterol improves because they've taken your advice, but in probably the majority of cases, the vast majority of cases, it's the same or worse. And you ask, okay, have you been doing these things? No. Well, and then if it's the same, you can say, well, try it again, come back in 6 months. Or if it's getting a lot worse, now you're saying, well, if I don't give you something now, and I send you home, and you obviously not going to be doing the interventions that I told you to do last time because you didn't do them last time, you're not going to do them this time. If I don't give you this medication, then your cholesterol is going to go up even higher, and you're going to be at even higher risk of getting a heart attack, a stroke, something like that. So you're obliged to give them the medication to try and treat them. We don't. You don't try to give people medications unnecessarily. You don't. It's not really. I mean, I don't know how it works in America. We don't really benefit from prescribing a medication. If I write a script to a patient, I don't get anything from that. I give the script to the patient, they go to the pharmacy, they either pay money, some of it's subsidized by Medicare, they get the medication, they take it. The only change is that hopefully they get better, or their cholesterol improves, or their blood sugar improves, whatever it is. I don't benefit from that except that the patient gets better. So I'm not really sure. I don't know if the system is different in America where the doctors get money for medications, but either way, the primary goal is to first line for a lot of these diseases is we call conservative management, things like exercise, diet, better sleep. And for psychiatric problems, it's even more important because I think Dr. K said this as well, but things like diet, exercise, psychotherapy have at least as good an effect for certain mental problems like major depressive disorder as, say, an SSRI tablet does. And so your first line treatment, and SSRIs come with side effects. And there's some nasty side effects that come with them that you don't necessarily want to have. And if you can avoid those, you should. And also the conservative management steps will often provide other benefits as well. And if someone is compliant, they're usually going to do better from those conservative management steps.
Yeah.
If they then do the conservative management steps and then still not better, then it's completely fair enough to then go into the medication pathway.
Yeah.
But I get what you're saying. In psychiatry, there's a sort of unrealistic expectation that you're going to
fix so much more than you can. Like with sending out the patient with the heart medication, if he doesn't die in an exercise, it's whatever. You can keep treating the acute things if they pop up. But with the psychiatry thing, like if you try to treat somebody with an SSRI and then they go home and they lay in bed all day and they don't get out, they don't make any friends, they don't talk to anybody, like that's not like an acceptable outcome.
Yeah, you're hoping that the SSRI will change that behavior, but sometimes it doesn't. A lot of times it doesn't. And yeah, like psychiatrists have a extra burden on them, I guess, that when they're talking to patients in their clinic, they're not just trying to find out what's wrong. Their conversation with the patient is part of the therapy.
Yeah.
It's not, I mean, GPs, I guess you could kind of say it's the same if they try and give you advice and explanations about why these lifestyle measures will help. I guess that's part of the therapy too, but it's more important for a psychiatrist.
Yeah. Like if you it feels like if you have a patient and you're a psychiatrist and that patient kills themselves, like it's like it can be seen as like a failure on the part of the psychiatrist or the psychologist to not intervene in time. But if you're a doctor and you've got a patient that eats themselves into an early grave or has an early heart attack in their 40s or something and dies, it's like, well, I mean, you did what you could, but it's not, at the end of the day, it's their life, not yours. Like the doctor doesn't get the same type of, I guess, like it feels like moral responsibilities like the psychiatrist does almost. It feels kind of shitty.
Yeah, 100%. I saw Dr. K's reaction to when Reckful passed away, and like you can just tell that he was obviously very, very upset about that. I mean, as you said, you're emotionally investing into that person a little bit in a way. I mean, you try and become a little bit more detached when you're giving therapy, but you can't help but have some sort of connection with that person, and obviously you're wanting them to do better. And so when he just broke down, I completely get that. It's hard to just maintain your composure when a patient of yours that you've been talking to for however long and trying to help them out of their rut then goes and commits suicide. It's an awful thing. Whereas, as you said, if you tell a patient to go do exercise, diet, take their medications, and they just don't do any of it and they pass away, I mean, yeah, it's not the same.
Okay.
It's definitely not nearly the same.
You mentioned COVID-19 stuff.
Yeah, you guys aren't doing too great.
I think we've had the most deaths yesterday since we had in late May. 1,200.
Oh no.
Yeah.
1,200 deaths in one day?
Yep, yesterday, and then 1,100 some the day before.
Oh dear. We're getting worried in Australia because one of our states has started getting a surge of a few hundred cases in a day. So I guess
cases a day. I think Florida is putting up 15,000 a day.
Yeah, I saw that actually.
Yeah.
What do you? Because the reason that I mentioned COVID is I saw something that you said a while ago about masks.
God damn it.
What's your position about?
Everybody should wear masks.
Okay, good. Look, I will give you the benefit of the doubt in that case, because the underlying thought is that coronavirus is spread by droplet, meaning that they're sort of large droplets from coughing or sneezing. They fall on the ground. They don't really travel very far in the air. It's not really airborne. Yeah. However, it seems to be the case from certain studies and from review articles that I've read. Now, I'm not an expert on COVID, but it seems to be the case that there is an element of airborne or aerosolized transmission, and that may be more prominent than we originally thought.
Yeah, that I want to say I saw something pop up 2 days ago. I think the N was pretty small. It was like 100 people, but it looked like something of like, I wish I could remember what this was exactly, but it was like there were like 100 or some people or whatever, and some number of people were infected. with the SARS-CoV-2 virus, but every single person that was wearing a mask wasn't infected. So it seems like, to be clear, on the arguments we had like months ago, my original argument was never that you shouldn't wear a mask. It was that the primary reason to wear a mask is to protect others in case you're sick and you're not aware of it, rather than protecting yourself, because you can still get infected. But it seems like as of recently, more stuff has come out saying that there's a greater protective element conferred to the person that wears the mask as well, more so than previously thought seems to be the case.
Yeah, that's fair enough. You know, and when surgeons wear a surgical mask in theaters, it's not so much to protect themselves as to protect the patient and the sterile field
environment
from
yeah.
your own, you know, breath and coughing.
Mm-hmm.
So yeah, I understand that. Has there been a mandate across America yet to wear masks, or not really?
No, we don't believe in the federal government here. Some states have mandated it, but the federal government has not. Although the federal government is mandating soon. What?
Do you live in California?
Yeah, I do, yeah.
Is it, do you have to wear masks there?
I think California has mandated. I know LA has. The city that I live in has for months now. Like, anytime I go out, I see people with masks on everywhere. It's ubiquitous. You can't go into stores or anything without them. I don't know about the rest of California, though. I don't know if that's only like an LA or an LA County thing, or if that's all of California or what.
I think it's actually a really big problem to not have a unifying national mandate about.
Yeah, you think so?
I do.
We had a
similar problem.
Yeah, that's like the catastrophic. That is the catastrophic error in the United States, is that we do not have a top-down, from a federal level, unified response to this. So every state and every city is left like waving their hands and they're like, oh, I don't know, should we close this business? Do we open this? What's an essential worker? Should we mandate masks? Like, nobody really knows. Every individual state and city is like figuring it out for themselves. It's insane. It's unbelievable.
Do you think that's just because Trump wants to avoid liability by becoming a figurehead, and if he puts down a mandate and he gets bad results, it's kind of up to him and then he gets the flack?
Well, it wouldn't surprise me at this point if a federal mandate comes very soon. That wouldn't surprise me. I don't know if it'll happen, but it wouldn't surprise me. Initially, there was no federal mandate because Trump didn't want to believe it existed, right? If the problem comes, let's say 50,000 people die, nobody noticed about it, then you sweep it under the rug and you win the election. Like, nobody wants to deal with a massive, pandemic, being the epicenter of a pandemic during an election year. So, you pretend, for a long time, Trump just denied that it was even a thing. He pretended that it was never, ever even like that big of a deal. When we had cases in the U.S., it's like, it's just a few people, who cares? And even as of recently, I don't know if you've seen the word embers flying around in the media, but Trump was Trump said something like, oh, there are a few embers of coronavirus left in the U.S. or something. It was like how he spoke about it. Yeah.
Chris Wallace?
It might have been, yeah, in his Wallace interview. Yeah, I watched that, yeah.
Yeah,
what did he had that was one of my favorite quotes of all time.
The embers?
No. The soon there's going to be no cases left in the United States, and Chris Hall was like, "Oh, well, are you sure?" And he's like, "Well, I'll be right eventually." What kind of fucking answer is that? You'll be right eventually, and when everybody's dead, when everybody's infected, what does that mean?
He's not wrong.
Yeah, he wasn't wrong. He was correct, but what an unbelievable statement. Oh my God.
That's right. Yeah, Trump's a very interesting guy. We enjoy watching him over here. I'm very glad he's far away. Sure. But look, yeah, we had a similar problem in the early stages of COVID in Australia, where our Prime Minister didn't really, he kind of was being very fluffy about things. He didn't really give us any solid guidelines of what we should do, what the states should do, what the restrictions should be. And then this, as you said, similar thing where this individual states here had to decide for themselves what restrictions are going to be put in place. And then eventually they were like, you know what, yes, we have to actually unify. That's when it started to get a lot worse. And then we actually finally got on track. We never did too badly. I think maybe part of that is the fact that Australia is very large in terms of area, and our populations are sort of spread out a little bit more. But I think the main problem is that there's always going to be travel between states. And if you have one state that is enforcing something really well and another state that isn't, you have a couple of travelers coming over from another state, that are highly infected, a state that has a lot of cases to a state that has low cases, they can
mess everything up.
You kind of need a unified thing, right? You need a unified approach. So I don't know what's going to happen in America. I think Did I see a picture of Trump wearing a mask?
Yeah, he's finally started doing it. He made a compromise. He's back to calling it the China virus, but he's wearing a mask at least, so.
He's calling it the China virus again.
Yeah, he started that, I think, a week ago. He calls it the China virus all the time now. The scariest thing is that, like, if you look at all the big states in the U.S. that are having these huge upticks of cases, like, we've on some of them, we haven't even peaked yet. Like, every day is a new high. And for states like Florida that I mentioned, their peak was 5 days ago. So that means that, like, deaths are going to continue to rise in the U.S. for probably at least the next week, if not 2, if not more.
I think it'll be, longer than that.
Yeah, just because, like, as the cases flow in, right, it's like the runtime for this is around 10 days, I think.
Yeah.
Yeah, so, like, so these deaths are going to rise more and more and more. It's pretty unreal. And we're coming out of summer, which is supposed to be, like, this was supposed to be the easiest time for it. Like,
I don't know what the evidence about that is, but either way,
I think the evidence was there's 2 things. One is more people are outside, where it's much harder to spread stuff like this. And 2, UV light, I think, is supposed to have like an eradication effect on this virus. I don't know if it's this one in particular, all viruses, but.
Oh, I didn't know that. Okay, interesting. Yeah, I think the people getting outside and. Isn't that what happened in Florida?
No. Okay, that's different. When I say go outside, I mean walking around your block and be outside, not in Florida where they pack the fucking beaches like fucking sardines. Okay, that was way different. That was probably not a recommended thing to do. Holy Jesus.
Yeah, fair enough.
Yeah.
I think you were talking about, this is probably a very minor point, I just wrote down a couple of things. You asked about, like, what is a virus, the structure of it, things like that. This is probably not very relevant, but basically viruses they have a DNA or RNA at their core. That's what allows them to replicate. And usually they're coded in a protein. Temperature can have an effect on viruses, and a lot of viruses become inactivated at higher temperatures, but we're talking like above 60, I don't know, Fahrenheit, 60 degrees Celsius. What's that?
60 Celsius, I'm gonna guess that's gotta be like 140 Fahrenheit or something.
140, yeah, you're right. So that kind of level is when heat can deactivate viruses. So
yeah, because I didn't think the sun, when people were like, oh, it's warm outside, so it should kill it. It's like, well, I have a small, like, food service background, and it's like, if you put a steak outside, like, even in, like, 30 or 35 degree weather, it's not going to kill the viruses, like, or any bacteria. No. You have to cook it at, like, it's 165 Fahrenheit, so probably, like, 50 or whatever Celsius, to actually kill anything.
Yeah. I assume Trump's walked back his recommendation to drink disinfectant.
Well, he didn't, to be fair, he didn't recommend that. He just... He just says a lot of words sometimes, okay? Okay.
I'm just joking.
Yeah.
But I watched that too. It's really entertaining.
Something that is.
I shouldn't be entertained by your country's. Anyway.
Hey, listen, it all goes downstream from us. So, one thing that is super, super, super scary to me right now is the way. I very, very hesitantly talk about this. Do you like vaccines, right?
Of course.
Okay, just making sure. I've talked to a lot of crazy people from Australia. Okay, you got a lot of loonies over there, right? But I'm super worried that for political reasons, America is fast tracking the research on this vaccine so unbelievably quickly. We have a name for it. What is it called? Like quantum fast track or something? Or there's like a name for it. That if this vaccine comes out and it's botched. Oh, warp speed is what we call it. Yeah, the warp speed that we're doing on this vaccine. If the vaccine comes out and there are like side effects or something is messed up about it, it is going to do like irreparable harm in an era where like anti-vax stuff is already getting more and more popular. And that's something that worries me so much.
What is this? So when you say they're fast tracking it, are they not requiring them to do as many safety studies or not requiring the same stringent protocols on safety? Is that what that means? I assume that's what that means, because that's usually the time factor.
Yeah, so I assume, I try to be the nicer assumer. Try to assume the best. My assumption is going to be that you're skipping queues, maybe above other FDA stuff, or skipping queues above other things maybe in line or whatever. But with the Operation Warp Speed, they're making it seem like it's possible.
Less tested.
Yeah. So Operation Warp Speed will promote mass production of multiple vaccines based on preliminary evidence, allowing for faster distribution. If clinical trials can confirm one of the vaccines is safe and effective, Yeah, I'm just so nervous about this getting
Mm.
botched.
Yeah, that's a fair point. I
Uh-huh.
think I don't know the exact protocols that vaccines have to go through. I know they're pretty rigorous in general, and that's why
Mm-hmm.
people at the start of this were saying if a vaccine is going to be developed, it won't be until maybe late next year or something, because it's going to need at least 1 to 2 years of proper efficacy trials and safety trials. You kind of do the efficacy trials first to make sure that it works, and then you got to do the safety trials
Mm-hmm.
second to make sure that you don't get any. Because if for a vaccine, your number of patients being treated is so high that even a 1 or 2% risk of adverse event is going to affect
Astronomically high.
thousands and thousands of people,
Mm-hmm.
and it's going to cause awful press coverage, and people are not going to trust it, they're not going to take it, things like that. So you really want really low rates of adverse events. You want something that's very, very safe,
Mm-hmm.
um, which most vaccines are and have gone through those rigorous testing with so many people in order to find those small numbers. Even if you test 1,000 people, 1 or 2 get an adverse event. You can't extrapolate that means it's a 0.1 or 0.2% adverse event rate. That number of adverse events is too low to give you the proper statistical power, right? So you need to actually test thousands and thousands of people,
Mm-hmm.
which can take a long, long, long time,
Yeah.
um, and be more expensive. So if that thing you're talking about, that warp speed thing, means they're going to be cutting that process of safety trial, then you're right. That could be a bit worrisome. Is that something that Trump has put in place and specifically wants to
Something that Trump, I
use?
think, is pushing for a lot because obviously he doesn't want this shit going on during the election time in a few months. Fauci, which is the head of he's not the head of the CDC. Is he the head of our health and human? I always forget the actual fucking title.
Fauci seems like a fairly sensible guy.
Yeah. What is his technical role in government or whatever? I always mix up the NSAID. Um, yeah, the National Institute of Health Director or something. National Institute.
Right.
Yeah. I think he's come out and he said like, hey, this is chill. It's okay. We're not laxing any of the regulations. But the head of another one of our medical federal bodies or whatever, I think resigned recently. He went back to like medicine and he left because he said that in a lot of the meetings where they're talking about, like which standards they need to look at, he felt like they had become so politicized that he didn't want to have any involvement in it, which is kind of
Oh
scary.
dear.
So, yeah.
Yeah, that's not a good sign. Um, Hopefully they don't. To be fair, I think a lot of countries are trying pretty hard now to get a good vaccine
Yeah, for sure.
on the ground. I think every country wants to be first, to be honest, but um, maybe that'll be the only way that America numbers actually go down.
Just waiting
Given
for the
that,
vaccine or just waiting for everybody to get fucking infected, I guess. Yeah.
yeah, I'm curious to see as well, because I don't know if you saw this. There was a case or a couple of cases of patients who had previously been infected with coronavirus, and they had antibody tests, and then they only lasted a few months or something, and they got reinfected a few months later. So
So
whatever the vaccine is, they'll have to be a little bit. They'll have to provoke a bit of more of an immune response, I guess. I don't know.
yeah, my understanding of that, as not a doctor, of course, is that just the presence of antibodies alone in the body isn't necessarily indicative of how much immunity you have to a particular virus. That I think historically with certain types of viruses, the antibodies do drop off after a few months, and that's pretty common. But as long as your body has
Yeah,
like the memory cells or whatever that can recreate those antibodies and spin it up pretty
that's
quickly, you're
true.
okay. Yeah.
That's true. It kind of depends on the number or the quantity of antibodies.
Mm-hmm.
So, like when you get your hepatitis B vaccine when you're a child, um, later in life when you get your serology testing done, it depends on the level of antibodies whether or not you then need a booster shot. So if it's above, 10, then you don't need a booster shot. If it's below 10, then you do.
Mm-hmm.
So yeah, you're right. You form memory cells, which are generally sort of lifelong, but at the same time, memory cells mean that when you get the infection, you will still get. Sorry, when you contract, if you contract the virus, you will still basically get the infection. You might produce your immune response a little bit faster, but you often will still have that infection, and you may even be contagious for a while. We don't know as much about this coronavirus as we
Mm-hmm.
do about things like the flu, but that is true.
Have you heard
The other
anything?
problem is if
Oh
coronavirus
god.
mutates.
Oh yeah, sure, yeah, which is something we thankfully haven't seen yet, or at least I haven't been made aware of it
Yeah.
yet. Have you heard about the potential neurological problems that might be occurring in people that have had this virus?
No, I've seen some interesting weird sequelae of it, like in people's skins uh, and other things. I haven't seen any brain complications.
Yeah, there's been a lot of people that there's been a lot of people. Was it a UK study? Neurological problems, COVID-19. I don't remember if it was in the UK or not. But apparently there are cases. This is dozens. Maybe it's not a big thing yet, but I've just been reading articles. I don't know if there's been a widespread study on it yet, showing that like a lot of people are having neurological problems as a result of COVID-19, which is interesting. But
Yeah, I've just looked up this thing. It's saying there's a study reporting 36% of COVID patients having neurological symptoms, headache, disturbed consciousness, paresthesias.
some of these
That's very
lasting
interesting.
like 3 months after the
Mm.
infection is cleared, which is spooky. Yeah.
Yeah, I mean there was initially when this was all happening, a lot of young people were sort of saying, well, it doesn't really affect young people. It's fine, not worried about it. But we had deaths of healthy 20-year-olds, and even if they don't die, sometimes they get such bad lung
Lung
scarring that it
problems.
gives damage for their life. Like it is something to be concerned about, even for young people. Is obviously there's a lot of cases that are mild, but you know, if you play games, you know that a few percent chance is not something you necessarily want to risk your life on.
Yeah. Yeah,
Yeah,
my favorite comparison. I never even thought of doing this actually, but was Asmongold talked about. Do you know who that is?
he streams World of
Warcraft.
Warcraft.
Yeah. Do you ever play video games?
Yeah, back in my university days, but I used to play sort of more like Dota and League and things like
Oh
that.
fuck! If you ever played an MMO, if you have to grind for an item that has like a 3% drop, that's like an easy grind. Like 3%, like that's damn. I got to kill like 30 or 40 mobs and I get a drop. That's actually like that's a pretty high percentage. Like the really hard drops are when you get down to like the point 0 x% drops, because now you're killing hundreds or thousands or tens of thousands of a certain mob to get a drop. But like 3%, 4%, like that's easy, you know. But like you'd have to like grind a lot of video games to have that mentality. And for a normal population, I noticed this is an observation I made. I swear to God, I'll publish a paper someday on this. Or somebody's probably talking about it, economics or psychology or whatever. I think that humans can perceive 3 stats. I think we understand 95%, 50%, and 5%, and nothing else at all. We either something is definitely going to happen, something's got like a 50% chance of happening, and something's got like a no chance of happening, and that's it. But like 30% or like 65% or like 15%, like people have no intuitive grasp of these numbers. If somebody says 30% to somebody, then they hear like, oh, that means it's never going to happen. Or 15%, oh, that's like 0% chance is what people think, I think, usually.
Yeah, I think that's probably true. I'm sure there are psychology studies about that. One of my friends is he does sort of finance stuff, and he was looking into psychology about like risk assessment.
Yeah.
And that sort of same principle where it's like, well, if you have like a 30% chance of something, people, might go for it. If they have a 1% chance, they'll just never go for it, even if, let's say you bet $100 and there's a 1% chance that you win $1 million, then statistically
You always take
that's a
that bet.
worthwhile bet.
Yeah.
But people will I'm sure if you polled people, they would never take it.
Yeah. Oh, fuck. There was
To
a
be
really
fair,
interesting paper on this. People actually act differently depending upon whether they're going to gain money or whether they're going to lose money, even if you give them the exact same odds. There's a lot of people are so bad at decision making when it comes to like analyzing risk or understanding like implied or like expected value of like an outcome or whatever. Like people are so bad about it. Yeah.
Yeah, 100%. It's really irritating actually, because sometimes when you have patients who have a lot of risk factors for something, but they don't have a disease that they're at risk for. So patients who are, have very mild diabetes, they have slightly high cholesterol, they're overweight, they smoke, and you tell them like, you can actually, there are sort of scoring systems you can even look up online about your risk of heart attack and stroke. And you can show people like, this is your percentage chance of having a stroke in this year or in the next 5 years. And I mean, the numbers are never going to be like, unless someone has like awful of everything, they're usually like 4% or 3% or 7%. And patients see that, they're like, oh, it's a 95% chance I'll be fine.
Yeah.
And makes them very unmotivated to actually change anything.
Yeah.
It's really difficult to convince them and people will ask like, "What's my chance, of getting this thing?" And you can either just be like, "It's high,"
Or
or
it's like,
then they
yeah.
say, "What does high mean?" And then you say, "Well, okay, it's like 7%." But I mean, 7% a year for 10 years is not a risk that you really want to take for your life, I guess. But people have, yeah.
Or 7%, like if you play poker, like that's more than a runner, and like people have hit that, like that. It's anything that you play, if you have any actual engagement with like odds related things, like those numbers seem a lot bigger than a lot of people give them credit for, or that those numbers are a lot bigger than people give them credit for. Yeah,
it's hard. It's hard to convince people.
You should, if you break that number down, instead of telling somebody their risk, you should give them like the percentile of the population that they're in. Like, oh, you've got like a 7% chance of a heart attack. And like, oh, okay, that puts you at like the 87th percentile of the population in terms of chances of having a heart attack. I wonder if people would understand that a little bit better.
That's actually a very good point.
Yeah.
That would, if you can use numbers to your advantage, I guess. Yeah, that's a good way to do it.
Oh.
What did you think of Trump's discussion about his MOCA, the cognitive assessment?
I just think it's funny that somebody brags about passing a cognitive assessment. It's like bragging about like passing your like a cranial nerve exam. Like, good job, you got like the bare functioning things that means your brain is still operational. Like, it's ugh.
Yeah, I know. I saw that. I can't believe. It's funnier because like people know what the test was. You can do it online. You can have a look at the test that he's talking about. So it's not like, an IQ test where you don't know what type it was. You don't know what the questions were. Like, you can look up the questions that he got. You can see that he just had to say how many words starting with F or whatever the questions are, and can you remember this date? It's going to be an interesting debate between him and Biden in the coming months. Is that still what's happening? It's going to be him versus Biden for your presidency?
Most likely, yeah.
Although I did see that Biden was recently trying to get some like climate change action going on, and it seems like he's trying to be sort of more progressive, if that's the right word. What are your thoughts on that?
I would vote for Brick over Trump at this point. It's not even close. I think Biden is okay. I think he's really old, which is kind of sad, but
they're both pretty old.
Yeah, they are.
I think there's a pretty high chance that whoever becomes president, there's likely to be a serious health problem in one of them in the years that they're president.
Yeah, it's
isn't
possible.
Biden close to 80?
Yeah, I think he's like 77 or something, isn't he? Biden age, 77. Yeah. But I mean, like the cabinet that Biden would have as vice president, his federal and Supreme Court picks, like everything would be so much better. So.
Oh yeah. I mean, look, there's no reason anyone would ever want to vote Trump in if they're a sensible person. I feel. You're right. There are some people in Australia who are a bit loony, but I feel like at least they're kind of a strict minority. I would say. I could be wrong about that. I feel in America it's more popular or it's more acceptable to be like a Trump supporter, Trump fanatic, or is that not true? That's the impression I get.
It still is. It's our country. We're very special, okay?
Fair enough.
Yeah.
It's look, there are some interesting things about America that I have noticed. I mean, obviously your healthcare system is not in a great state. I don't know if you know about the Australian healthcare system. We kind of have a public system with Medicare, but we also have optional private insurance. So everyone is baseline covered by Medicare. So all Australian citizens have Medicare. So when you come into hospital, you go see a GP, you get Medicare rebates, things are paid for. But people who want to can then pay private insurance for private health insurance so that they get certain benefits. So for instance, when you if you're admitted to hospital and you need surgery, you get the consultant, you get the boss doing the surgery themselves rather than the training like registrar or resident, whatever you call it in America.
Yeah.
So you get some benefits. I don't know why America hasn't put in something like that where you kind of still have that private option, because obviously people are very keen on having that, and that's fine. You can have that as well as the public system. But as far as I'm aware, your sort of public healthcare system doesn't just baseline cover everyone.
No. We have two forms of public health care. We've got Medicare and Medicaid. Medicare covers you automatically when you turn older, and Medicaid covers people that are below the poverty line.
So it's basically saying we have public health care for everyone as long as they're old or poor.
Basically,
is that
yeah.
kind of?
Well, but then the problem is that poor thing is like,
And that will be hard to test, and people can find ways to
yeah,
deny it.
like healthcare is really expensive. Just because you're above the poverty line doesn't mean that you can afford, like anything related to health in the United States. Like for
Yeah,
me,
it's
I
really
just got.
interesting.
Do you know what the Tdap booster is?
Yeah,
Okay, I
the
think
vaccine bit. Yeah.
yeah, I think I paid for that in cash, and I get like a pretty big discount because I pay in cash, and I think that cost me $180 USD.
Mm, yeah.
So
Okay.
250 Australian dollars for me to just to get
Gotcha.
that booster. Yeah.
Yeah, that's it's interesting because America has some fantastic doctors and medical schools, and they have like a pretty good training system, and they do a lot of really top tier research.
Hmm.
Um, but then at the same time, they have quite poor health outcomes just because of the healthcare system there.
We have no
Um,
access. Yeah.
yeah, it's kind of frustrating to see because I feel like the rest of the world is just looking at you guys and being like, "Come on,
What
just
the fuck? Well, that's
just
what I
do this."
feel about like the coronavirus stuff. Like I'm not patriotic at all. Fuck, I don't care about this country. Fuck this country. But we have a lot of production. We have a lot of technology. We have a lot of very fucking smart people here. The idea that we sat on our ass and we couldn't figure out how to make a test in 1.5 months after we banned travel from China, we just couldn't figure it out. I don't believe that. That's fucking bullshit. Like we dragged our
Mm,
feet on that so hard. There's no excuse that like any other country in the world should have been able to beat America to the punchline. On like if we were driven to do it, if we were motivated to do it, like I think it would have gotten done. But we lack the political will to do so much. It's like unbelievable. Ugh.
yeah, if you had a different president that took it seriously, they would
Yeah.
have put funding into finding tests, finding cures, finding vaccines, etc.
Hmm.
National mandates about social distancing, mask wearing, fines, whatever you needed to do. I mean, that's kind of what places like China, South Korea have done, is a much more strict nationwide approach, which has obviously worked in their favor.
Yeah.
Um, yeah, fair enough. Because I feel like this is a bit more generalized, but the culture of America, correct me if I'm wrong about this, it's very it's centered around like hyper individualism and that sort of like American dream thing.
Yeah. Ultra
It,
liberal, very anti-federal government. Yeah.
yeah, which has its pros and cons. The pros being like it does create some fantastic individuals and high achievers and pioneers in areas because it gives people with good ability the sort of confidence and push to strive to increase their ambition to do more. And then the cons is that the people with low or no ability then become very confident in themselves when they probably shouldn't be, and then become the president or whatever it may be.
Yeah. Yeah. Yeah.
Um,
It sucks.
whereas I think, I mean, I don't know about Europe, but in Australia at least, I mean, it's more about like giving everyone a fair go. It's kind of like, you do your best, obviously, but I don't think anyone in Australia, or at least very minimal number of people, would ever be against universal healthcare,
Hmm.
or say they didn't want it, rich and poor alike. Um, so I'm not sure how that's going to go. Although it seems like the main reason that the Republicans are winning elections is because of your electoral college system, and I don't know whether that.
No, people can blame the electoral college, but no, Republicans legitimately have a lot of support in the United States. They do. Maybe some elections might have gone a little bit differently, but I mean, look at the number of Republican governors. Look at Republicans owning the House and the Senate for 6 years under Obama. Like, there's a lot of Republicans here. Yeah, that we have to deal with that. That's not really ominous. I mean, like, but we need to like change the thought in America, not like kill them all. But
Yeah, fair enough.
uh-huh.
Well, yeah. Do you have any other questions or things you want to talk about? That's mostly what I sort of had written down.
I don't think so. No, I think I'm pretty good. Yeah.
Yeah, cool. Thanks for having me on. If you do ever have any questions or you're not sure about something, just send me a message on Discord or whatever. But it was great to talk to you. I just honestly, my main goal was talk a little bit about mental health stuff to the stream. I was a bit nervous at the start. I apologize for my voice. And a little bit about COVID and just to confirm correct information. Maybe just make sure people understood these things a little bit better. I do think it's really good that people are talking about mental health stuff more openly. I think that Dr. K is doing a great job. I think that it's a good discussion to have, especially among the gamer community, which probably has a lot of
mentally ill people.
Mental health issues. Not mentally ill people per se, but mental issues or things that that advice about how to improve your mental state could probably help a great deal. And yeah, as I said before, even if you've tried, say, a therapist or a psychiatrist and it wasn't the greatest experience, it's worthwhile trying to find a different one. It's very dependent on the person, and you want to find someone that you trust and you feel isn't judging you. You can be honest with. If you're not honest with a therapist, it's not going to work. That's the first point. Like, there's no point lying to your therapist about anything. It's just not going to work. If I'm treating a patient and they tell me they're taking their medication every day, I see that their cholesterol's gone up, or I see that their blood sugar's up, or whatever it is, it's then puts me in a tough spot where do I not believe this patient and then try to convince them that actually I think you're lying, or do I then say, okay, well, actually maybe they're telling the truth and maybe there's another reason, and then I go on a wild goose chase looking for other causes. So it's never good to lie to your doctor in general. Obviously there's always patient-doctor confidentiality, and so you just want someone that you can be open and honest with, talk to about whatever problems you're having. If you do not feel like they're listening to you or they don't understand your problems, that's quite possible. They're going to be psychiatrists who are older, maybe not as good. Just try maybe give them a chance. If you're not having success, switch to another one. It's worth trying. Anyway, that's all I wanted to say.
Okay. All right, cool. Well, thanks for the conversation. If you ever hear anything else you want to talk about, or if I ever can think of anything, yeah, we'll reach out.
Sounds good. Take it easy.
All right. Have a good one, man. Bye.
Cheers. Bye.
It's called the U.S. flag, you stupid fuck. This is the only flag that the United States federally has and recognizes. Why the fuck are you acting like a different